Now, how do we manage patients with recurrent acute otitis media? Now, whatever we spoke so far was in general terms for acute otitis media. Now, let's understand about recurrent acute otitis media. So, for managing patients who have got recurrent acute otitis media, first and foremost, you have to alter the risk factors. There is something that is causing recurrence. We have to identify what is that risk factor. It could be using pacifier, it could be non-breastfeeding, it could be bottle feeding, it could be passive smoking, it could be various other causes. So, if you can identify what is that risk factor that is predisposing, you have to treat and avoid that risk factor. So, the most readily modifiable risk factor is exposure to other children. So, typically in daycare patients, the children are going and they see that there is a cycle of transmission of infection from one child to another child to another child. So, somewhere you have to break the cycle. So, prevent at least for a few days exposure to other children. Once the child has had complete recovery from acute otitis media, after about a few weeks, then you can send the child to the school. But preschool children, if you are sending for daycare and the child has just resolved an infection, goes to the preschool, again develops an infection, recurrence is bound to happen. So you are going to stop or wait for the child to become asymptomatic for at least a few weeks before you resume the school. So exposure to other children is something that can be avoided. That is something that is very commonly done. Avoid feeding in the in the sleeping position, and ask the mother to feed the child in semi-upright position so that there is no regurgitation via the eustachian tube. Avoid passive smoking, restricting the use of pacifiers, and breastfeeding at least for 6 months of age. Now, when there is recurrent AOM, there is a role of antibiotic prophylaxis. So here, prophylactically, we are giving antibiotics. How long, what antibiotic is what I'll discuss. Now, amoxicillin can be given in the dosage of 20 milligrams per kg once daily, or sulfadoxine, which is given for 75 mg per kg per day. So, you give sulfadoxine. This sulfadoxine is given in two divided doses. Unlike amoxicillin, which is given as a single dose, this is given as two divided doses. Is reasonable in children in whom which kind of AOM, who have 3 episodes within 6 months or 4 episodes in 1 year. So you will give prophylactically antibiotics. How much dosage I have discussed. How long will you give this? It is given for 3 to 6 months during the winter. And antibiotic prophylaxis may reduce the incidence of acute otitis media. It does not reduce the length of time with otitis media with effusion. So it can definitely reduce the attacks of acute otitis media, but if there is an otitis media with effusion where there is sterile fluid in the middle ear, can antibiotic resolve that? No. Antibiotic has got no role in OME, but can it reduce the incidence of AOM? Yes. Antibiotic prophylaxis is most appropriate for children who are not prone for OME. So, if there is a set of children who have AOM and can have middle ear effusion which could be persistent resulting in OME, no role of antibiotics. But if there is acute otitis media and if the child is not prone for OME, then can you give antibiotic prophylaxis? Yes. Amoxicillin in a dosage of 20 milligram per kg as a single dose, or sulfadoxine as a 75 milligram per kg. This is given for 2 divided doses. How long will you give? 3 to 6 months, especially during the winter times. And prophylactically, when you give, the child will have a reduced incidence of possibility of developing an acute otitis media. Ventilation tubes. What is the role of ventilation tubes? It is the first line surgical therapy for recurrent acute otitis media. So, if there is recurrent acute middle ear infections, then you can do. Whenever you are inserting a ventilating tube, of course, you have to do a myringotomy and insert the ventilating tube. Children are generally considered candidates if they have 3 to 4 episodes in how many months? 6 months, or 4 to 6 episodes in 1 year. So, if they're having so often, then you better put a ventilating tube so that even if there is a pus, it's able to drain out without causing any further complication. They reduce the frequency of episodes and decrease the duration of otitis media. So, one is when you put the ventilating tube, the disease duration gets reduced and the frequency, like not 3 to 4 episodes in a 6 months period or 4 to 6 episodes in 1 year period. You will not have that. You will have once in a year or twice in a year. So frequency will also reduce, duration also will reduce. All the otitis media can still occur in the form of otorrhea. Many episodes are not accompanied even by any symptoms. So there is no pain, there is no fever, and can be treated with ototopical antibiotics without oral antibiotics. So when you put a patient on ventilating tube, directly you can give ear drops and ototopical drugs that go to middle ear and act. And the need for giving systemic antibiotics will reduce. So antibiotic prophylaxis can be given, but if you're putting a ventilating tube, the need for antibiotic prophylaxis is reducing. So that is what we do for recurrent AOM, where the first line surgical therapy is going to be ventilating tubes. Xylitol. What is xylitol? Xylitol is a common sweetener that we have in chewing gums. And what does this xylitol do? It is inhibiting the pneumococcal growth and attachment of pneumococcus or the Haemophilus to the nasopharyngeal cells. So when it inhibits the attachment of the bacteria to the nasopharyngeal mucosa, would there be an effect on the eustachian tube or the middle ear? No. Automatically, will the incidence of recurrent AOM come down? Yes. So we can give this sweetener, we can ask the child to chew the chewing gum and hence reduce the incidence. Now, study in daycare nurseries using chewing gum or syrup of xylitol have shown reduction in 30 to 40% in the occurrence of AOM. So yes, it's a simple therapy. You just give chewing gum or a xylitol syrup that will help us in reduction of incidence of acute otitis media. Given the very large quantities, they must be consumed, and potential concern over the safety on consumption, it cannot yet be recommended. But can we recommend this in a day-to-day practice? No, because it's a sweetener. Sweetener associated complications other than ear we can possibly have. So we cannot give this over a long period of time and in huge quantities, and hence it is not a recommendation, it's only a trial phase medication.